Thank you so much, and good evening to respected chairpersons. Thank you, team Diabetica 2025 Vadodara. Thank you, Pratap sir and team for inviting and giving me this opportunity. In 70s to 80s, that there can be some incretin-based hormones secreted from the gut cells, which are responsible for releasing insulin after oral glucose or oral nutritional intake. And then these two hormones were identified, which we now call it as a GLP-1, glucagon like peptide, and GIP, which are secreted predominantly from the proximal versus the distal small intestine. So this incretin effect and the mechanisms of actions of different GLP-1 receptor agonists, I think we all are aware about that. It produces the insulin dependent, glucose dependent insulin secretion, glucagon suppression, appetite suppression at the level of hypothalamus, brain, reduced energy intake, etc. Promotes satiety. So the much noise about the GLP-1 receptor agonist that we call about has been with regards to GLP only. The GIP has been relatively forgotten until now, and after the recent approval of Tirzepetide, for example, in our country, and as sir already said that all of us are getting the noise about the prescription or about the inquiry regarding the Tirzepetide, for example. So this Tirzepetide has become recently approved as an indication for treatment of obesity as well as in hyperglycemia and type 2 diabetes. So just to brief about the stark difference between the GLP and GIP, both are incretin hormones, both are going to produce the glucose dependent insulin secretion, glucagon suppression, for example. The only unique property of the GIP is at the level of hypothalamus, it reduces nausea. So it reduces, or it has got the similar or even lesser levels of the tolerability issues, GI tolerability issues, as compared to conventional GLP-1 receptor agonist. And the most important thing with the GIP hormone as an part of incretin is that its action on the adipose tissue. It increases the energy expenditure at the level of adipose tissue. So it improves insulin sensitivity at the level of adipose tissue, and hence it prevents the ectopic fat deposition at the another sites. For example, it reduces the fatty liver, it reduces the fat deposition in the pancreatic beta cells, and it increases the energy expenditure at the level of adipose tissue. So the GLP-1 receptor agonist based treatment, single, dual, triple, for example, the past and present we have discussed in previous session by Navneet sir, and all these treatments for the use in diabetes. But when it comes to the weight loss, non-diabetic patients, the approved treatments or approved GLP-1 receptor agonist has been the semaglutide subcutaneous, which is called the Wegovy in the United States, liraglutide, which is 3 milligram liraglutide Saxenda, and Tirzepetide. So these are the only three FDA approved GLP-1 receptor agonist. But when in this particular talk, if I am talking about the molecules dual and triple agonist beyond Tirzepetide, so we are not going to discuss much of the previously available or the currently available GLP-1 receptor agonist, including Tirzepetide. So we experienced this wave of hyperglycemia reduction and weight reduction with semaglutide, and we were in awe that semaglutide, and everyone was asking about the semaglutide, whether I can take semaglutide. My relative has started semaglutide somewhere in UK, somewhere in USA. We have oral availability of the semaglutide, whether should I start the treatment for myself for obesity or not. Next, nowadays we are experiencing this wave of Tirzepetide, even bigger wave as compared to semaglutide, right? And because it is the approved drug for the treatment of obesity even in non-diabetic individuals, and we are not sure what even bigger thing is available or what even bigger wave is going to come. So there are some important molecules in pipeline for both GLP, GIP and other receptor agonists also, and they have shown the promising results for the weight reduction as well as the hyperglycemia reduction. So for that, if we divide the treatment or the future of the incretin based therapies, the new and improved oral formulations, I think we are going to skip. Navneet Shah sir has already spoken about the high dose oral semaglutide, has recently completed the phase 3 trial of 50 milligram semaglutide, has produced the promising results of weight loss and hyperglycemia reduction. The another oral incretin based therapy, as sir already said, orforglipron, the first in class of a glipron, which is a non-peptide GLP receptor agonist. As compared to semaglutide, which is a peptide GLP-1 receptor agonist, it requires a specialized technology to be absorbed from the stomach epithelium, and it has got a bioavailability of only 1% or so. But because of its long-acting half-life, we are giving it once in a day. But this non-peptide glipron, it has got the good bioavailability from the stomach epithelium, and that's why it is given once in a day, and it produces the weight loss to the tune of 15%, up to 15%. So this is a big thing, and that phase 3 trial has, I think recently it has been completed, and results are going to be available for the phase 3 trial also. So if we skip the oral GLP receptor based treatments which have already been discussed, the dual agonist which are yet to be available or which are in pipeline and which have shown the promising results. The first is the co-administration of GLP-1 with amylin agonist. So for this, which is the combination of semaglutide and cagrilinotide. So cagrilinotide is first of its kind of an amylin agonist, and combined with semaglutide, the study of its phase 2 trial has been completed. It has got the promising results by Novo Nordisk. In its first phase 2 trial, it has got the HbA1c reduction by the cagri-sema up to 2.2%, which was way higher than the monotherapy cagri versus sema given separately. And the weight loss with the combination of cagri-sema has been to the tune of up to 15% at the end of the trial of 40 weeks. And the weight loss has been significantly higher than the use of these both molecules given separately. So the position statement as regards to cagri-sema as of now is that the mean change in HbA1c with cagri-sema is way higher than the cagrilinotide, numerically higher than the semaglutide. Although in the trial, this HbA1c reduction was statistically not significant between the cagri-sema versus sema, but the weight loss was significantly higher in the combination group of cagri-sema as compared to semaglutide alone or cagrilinotide alone. And the phase 3 program has been initiated by the Novo Nordisk, which is called the REDEFINE trial. The dual agonist, Tirzepetide, we know dual agonist of GIP and GLP-1 receptor agonist, and it is going to be discussed somewhere in the on the second floor in a separate session. So we are not going to discuss Tirzepetide. Sir has already spoken. Another kind of a dual agonist is the agonism of the two receptors, which is the GLP-1 and glucagon receptors. Now this is something new. Now glucagon is a molecule, we know it's kind of a stress hormone, anti-insulin hormone, right? It produces the hyperglycemia. So we know glucagon as a glucose increasing hormone, it antagonizes the insulin action. So how it is to be approved or how it is to be used in patients with diabetes or in patients with obesity. So that was the original thinking. But when given in a supraphysiological doses, the exact mechanisms are yet to be understood, but in animal studies, it was shown that this glucagon also mimics some of the properties of the incretin based hormones, and it acts at these kind of incretin hormones as well as the glucagon incretin receptors as well as the glucagon receptors, and collectively helps in reducing the energy expenditure and reducing the body weight loss and fat deposition in the liver. So this agonism of the glucagon receptor and its collective, this is the structure of the glucagon, and this is the structure of the combination of the GLP plus glucagon receptor. So this addition of this C-terminal extension, which is called the CEX, C-terminal extension attached to the glucagon, and it combines the properties of the incretin as well as the glucagon receptor agonism. So dual receptor agonism, it produces even higher weight loss as compared to GLP-1 receptor agonism alone. And if we see the first example of the GLP-1 and the glucagon receptor agonist is the cotadutide. Dutide is for the dual agonist. So all the kinds of dual agonist in this kind of category, they are called the dutides. Like the semaglutide, dulaglutide, they were monoagonist of GLP-1. Now dutides are the dual agonist. So first of its kind was a cotadutide, which was developed, I think, with from the AstraZeneca. The data with regards to the weight loss or the HbA1c reduction were good as compared to placebo. But when we are already having the Tirzepetide in our basket, which produces the weight loss of up to 15 to 20% in non-diabetic individuals, the cotadutide produced the weight loss of only about 5 to 10%. So that was some kind of a setback with regards to this development of the dual agonist molecule with GLP-1 and glucagon receptor. But the important finding from this particular phase 2 trial of the cotadutide was there was almost 3 to 4 times higher reduction in the triglycerides, 3 to 4 times higher reduction in the LDL cholesterol levels, and a significant improvement in the liver steatosis and liver fibrosis. So although weight reduction was kind of at par with oral semaglutide, but the metabolic advantages in terms of the triglyceride reduction and fatty liver reduction was significantly or way higher as compared to other GLP-1 receptor agonist alone with the use of this dual agonist cotadutide. The another of the this dual agonist with GLP and glucagon receptor is the survodutide. Survodutide, it going beyond the cotadutide, contrary to the expectation with the experience from the cotadutide, survodutide significantly or tremendously produced the weight loss at the end of 46 weeks with the higher dose of survodutide producing weight loss up to 18%, almost close to Tirzepetide. Now, if there can be a question that what is the difference between when we are already having Tirzepetide, what's the need for survodutide? But making or the manufacturing GIP receptor agonist is quite challenging when it comes to the basic biological science. Making the agonism of the GLP and glucagon is quite easier as compared to the making a GIP receptor agonist, because GIP is kind of a variable receptor and it makes a stringent technology to develop GIP receptor agonist that can hamper some of the it can make easy for some of the pharmaceutical companies to make this kind of dual agonist as compared to GIP receptor agonist. So the survodutide produced the weight loss of up to 18% in its trial, phase 2 trial. Phase 3 trial for survodutide is initiated, and it's going to be, results are going to be available by a year or two. Now going on to the triple agonist. So the first of its kind of a triple agonist. So as I said, the dual agonist were known as a dutide, triple agonist is trutide. So the first of its class, that is trutide, is a retatrutide being developed by Eli Lilly. I think this big wave of Tirzepetide, once it wanes off, then the another big wave of retatrutide which will come, and we are going to be discussing this molecule after 2 or 3 years in the same conference. So this has produced the triple agonist, GIP, GLP and glucagon receptor agonism, and combined, if we see the results, magnificent, up to 25% weight reduction. Now the sir is here, which sir is going to discuss the bariatric procedures. I don't know, sir will give us the idea regarding these, but many a times at the end of 48 weeks is not so long. At the end of 48 weeks, if we are getting the weight reduction of 25%, it becomes almost 50% to what many of the bariatric procedures are producing. So very promising results in terms of weight reduction, irrespective of the baseline BMI. Even the people who had the baseline BMI of less than 25, less than 35, they got the weight reduction of up to 20% as compared to 25% with the patients who had the BMI of 20, more than 35. So if we conclude regarding the retatrutide, 24% average weight reduction in non-diabetics, 17% in diabetics. Side effects were almost comparable to all other available GLP-1 receptor agonists, and the results are almost comparable, not comparable, but I can say that close to 50% of what many of the bariatric procedures are producing, and phase 3 program of the retatrutide is underway. In 2 years, the data will be available. So if we end this particular session in the next few slides only, the incretin and the reported or the trials reported weight loss, liraglutide produced 6 to 8% weight loss, dulaglutide close to 5 to 10%, semaglutide oral, which we are having Ribelsus, 5 to 10%, injectable semaglutide higher dose, which is Wegovy, more than 15%. So higher weight reduction, which is the injectable semaglutide, Wegovy, higher dose, oral semaglutide up to 15%, and Tirzepetide between 18 to 22%. And these all future generation incretin based therapies, dual and triple agonist, if we are talking about, almost all these which I have mentioned, they have completed their phase 2 trials successfully, and they all are in their phase 3 trials. Some of these are at the end of the phase 3 trials. Orforglipron, Cagrilintide, survodutide and retatrutide. So almost all they have got the weight reduction of close to 15%, except the retatrutide, which has got the weight reduction of 20 to 25% in non-diabetic individuals. Lastly, when we are talking about the weight reduction, almost all the GLP-1 receptor agonist or any of the weight reduction, even if you are losing weight with the use of medical nutrition therapy or with the exercise or with the medical therapies or with bariatric surgery, it's not that only fat mass is lost. It's the combination of fat mass as well as the lean body mass loss. And with the Tirzepetide, we have got the data also that lean body mass loss is approximately 10 to 15% and rest all is fat mass. But lean body mass loss, even of a 10%, it matters to a chronic or non-communicable diseases when we call about the diabetes and hypertension and dyslipidemia. So for that, there is one important molecule being studied in phase 2 trial right now, which is the bimagrumab. Bimagrumab is the monoclonal antibody against the activin type 2 receptors in the skeletal muscles. Bimagrumab has been studied in animals, which has shown to increase the lean body mass, to increase the muscle mass. Now combining with the bimagrumab along with semaglutide, and this study has been underway with the help of Eli Lilly, I think, and they have got good results in the animal studies, phase 1 trials, that there was even higher weight reduction as compared to semaglutide alone, and none of the lean body mass was lost. All of the weight loss which was produced with the combination of bimagrumab and semaglutide was because of the fat mass loss and preservation of the lean body mass. And with the to end this session, GLP-1 receptor agonists have got the multiple mechanism of actions, and many of the indications are yet to be approved. We have known that these weight loss and the hyperglycemia reduction with the use of GLP-1 receptor agonists, they are benefiting heart failure they are benefiting fatty liver, they are benefiting NASH. There are some reports of improvement in the some parameters of the neurocognitive disorders like Alzheimer's disease also, but they are yet to be studied in many of these disorders, and we are going to experience many of the new indications for these molecules as well. With this, I would like to end here. Thank you so much. Over to organizers.